Hi, welcome to Cafe 229. Today, we're very happy and honored to have Dr. Judith Beck. When we think of psychotherapy nowadays, we think of cognitive therapy. And when we think of cognitive therapy nowadays, we think of Dr. Judith Beck. Hi, Dr. Beck.
Hi.
We're very honored to have you because you're such an important clinician of our time, especially when we're thinking and talking about cognitive therapy. Just curious from my personal point of view, though, did you always want to be a great clinician when you grew up?
No, in fact, I never considered going into therapy or into psychology. But that's because when I was about 6 years old, I decided I wanted to be a teacher. And I always loved working with kids and kind of dealing with kids, managing kids just came intuitively to me. And in fact, I started off my career as a teacher. I taught kids who had learning disabilities. And again, I was kind of an intuitive teacher. I learned a couple of things, I think, in school, but mostly I figured out what to do on the spot. And I taught kids with learning disabilities. So one of the skills that I developed was the ability to take complicated concepts and explain them in terms that could be easily understood. But eventually I decided that I might someday want to be more than just a classroom teacher, and then I would need an advanced degree. I already had a master's in psychology and education, so I decided to get a PhD, and mostly I did education at the beginning, and then I kind of switched to psychology. And the reason that I didn't, probably hadn't approached psychology earlier was that I didn't realize that something like therapy, especially CBT, is a set of skills that could be learned. I just thought that you had to kind of be a born therapist the way that I felt as if I had been a born teacher. But I found that after being a psychotherapist for about 5 or 10 years in CBT, then the whole process did become much more intuitive to me. Mm-hmm. And then I kind of came full circle because mostly what I do now is education. I'm the president of a nonprofit organization in Philadelphia, the Beck Institute for Cognitive Behavior Therapy. We have a small clinic and I still see patients, but mostly what we do is national and international training in CBT. So we're primarily a training institute. And I have to tell you, we got so lucky because before COVID hit, we had already produced online courses for people to take. And so we were very lucky that when the pandemic started, we were able to pretty seamlessly just transfer all of our training programs online. And we found, for example, that we could do workshops online using the same kind of interactive activities as we could in person.
Wow, so it's really come to a full circle where you want to start as a great educator and then you sort of go around and now you're an educator for the clinicians and the general public.
But I still love seeing patients too. I still love doing supervision. So I really enjoy the clinical work, but teaching has always kind of been in my heart.
So we know that your father, Dr. Aaron Beck, is the sort of founder of CBT. Did he have any influence on you of being a clinician? Just again, out of my personal curiosity, like, did you know he was doing some great work?
So let's see. The first time that I knew that there was something really special about my father, he had written some books. So I knew that most fathers didn't write books or textbooks or things like that. But I was a freshman at college at the University of Pennsylvania, and I took a course from a very well-known CBT-oriented psychologist, Martin Seligman.
Okay.
And Marty handed out the Beck Depression Inventory to every student in this 200 introductory class to psychology. And I said, whoa, I know about this. So and he did talk a little bit about my father's work in that course. And then later on in my college years, I went to the annual conference of I think it was the Society of Clinical Psychology in Philadelphia, where we lived and where I went to school. And the reason I went was because my father was being given an award, but he had laryngitis. So he typed out his speech and I read it for him. But before I did that, the person who gave him the award read out my father's voluminous number of accomplishments, and why it was that he deserved this award. And I kept on kind of checking off in my box. No, didn't know he did that. No, didn't know he did that. Didn't know he did that. So, I think that was fine.
Yeah.
Some people think that I became a teacher almost in opposition to my father because he was so famous and so forth. But that wasn't it at all. It was just that I had always wanted to be a teacher. He did think, though, that I would be a good psychologist. And, certainly talking to him and learning more about CBT made me want to study, beyond education and really to study psychology. And so, yes, of course. Now, growing up, though, I think we had a pretty normal household. This was, I was born in 1954, so this was in the 50s and 60s.
Sure.
And my father had always been kind of a workaholic. And so it was really my mother who had most of the care and feeding of us 4 children. But she was unusual too, because she went to law school when she had 4 kids under the age of 9 and a very busy husband. Later in her career, very productive, she became the first female judge in the appeals court of the state of Pennsylvania.
Wow.
So she, in her own right, broke glass ceilings. I remember I was so unbelievably lucky. My mother said to me when I was probably a teenager, Judy, you should really do whatever you want to do in life. If you want to stay home and have kids, that's great, do that. If you want to have a career, that's great, do that. But there was never any pressure on me to follow in my father's footsteps or to do anything very important. And I never actually thought that I would necessarily ever do anything more than being a classroom teacher. But I have to say it's been very rewarding to be able to do lots and lots of things.
Sure. And I guess I ask because sometimes, how it's our family member never listen to our comments or advice on anything related to psychology. That's why I was wondering how your father influenced you. Of course, I think your position is similar to Anna Freud in some way, right? Because Anna Freud continue her father's legacy of Sigmund Freud, and you're doing the same thing. You're continuing.
Well, I've heard that comparison before, and it's highly flattering.
But I think some of our audience probably don't know much about CBT, so I think maybe we should explain a little bit what is cognitive behavioral therapy and why nowadays when we think of therapy, the most common therapy we hear about is cognitive therapy.
Sure. So I'm going to talk about the form of cognitive behavior therapy that was developed by my father, Aaron Beck, in the 1960s and 70s. And he and I and colleagues all over the world have continued to refine this form of CBT throughout the decades. So CBT has evolved, but basically it's a psychotherapy, a form of talk therapy that's based on the cognitive model. And let me just give you an example of what that is. So people who are listening or viewing this conversation right now might have a variety of emotions. Maybe some people are feeling really annoyed because they thought it was going to be a really good interview and it turned out not to be.
Sure.
So they might feel annoyed and they might think, well, this really isn't very good, but I have to sit here and watch it. So they would feel annoyed. And they might kind of tune out. Their behavior might be to start thinking about other things or doodling on a pad or checking their phone. Mm-hmm. Someone else watching this interview might think, wow, this sounds really important, but I don't really understand everything. I think I really should. Is there something wrong with me? And they may feel sad. And then they too might lose focus. Mm-hmm. They might try to listen, but be losing focus because they're feeling so sad. Another person might think, wow, this is really great. And that person would probably feel happy and might pay even closer attention. Mm-hmm. So the situation is the same in all of these cases. And that is listening to our interview together. Sure. But people can have a variety of different emotional reactions. And their emotions will be associated with whatever they were thinking. So if they have angry kinds of thoughts, they're going to feel angry. If they have anxious thoughts, they're going to feel worried or anxious, sad and happy, and so forth. So it's not a situation that directly leads someone to feel happy or sad or angry or anxious. It's their interpretation of that situation. And specifically, the thoughts that just seem to pop up automatically into their minds. They're not necessarily trying to have these thoughts. These thoughts just seem to pop up, but do have a significant impact then on how they feel and what they do. When people are in a lot of distress, often their thinking is not 100% accurate or realistic. And certainly it's not always helpful. And we find this quite a lot, particularly when someone has a psychiatric disorder like depression or anxiety or substance abuse or post-traumatic stress disorder or an eating disorder or personality disorder or severe mental illness like schizophrenia or bipolar disorder. Not all of their thinking is inaccurate or unhelpful, but a lot of it is. And so one important thing that we do in CBT is to help people become more aware of their thinking when they either notice that their mood has gotten more negative or when they're engaging in some behavior that isn't very helpful. And we teach them to figure out what their situation is, what they're thinking, what's going through their minds, and then figure out what their reaction is. So we kind of teach them the cognitive model, and they begin to view their experience in light of the cognitive model.
So people are usually like drowning in their thoughts almost in some way and influenced by the way they think. So how I think is how I feel, in other words.
Exactly. And people have characteristic themes in their thoughts. So, for example, a depressed patient might think, I can't do anything right. If I try to, balance my checkbook or look at my budget, I'll just make mistakes. I shouldn't even try to clean up my house because I'll just be too tired and I'll put things someplace and I won't be able to find them. So people have characteristic themes in their thoughts. The themes that in the thoughts that I just mentioned is probably one of helplessness or incompetence. So someone might think I'm helpless or I'm incompetent. That may be the basic belief that they have. And so no matter what situation they enter, they may see it through the lens of this negative belief. This is especially if they're depressed. Now, when they're not depressed, they might think that, oh boy, okay, so I have strengths and weaknesses like everyone else. Or although I can't do everything, I can do some things well. But when they're depressed, this idea that they are incompetent is going to be very strong in their minds, and it's going to influence then their perception of situations. So again, we're going to get them to look for times when they are not behaving in a reasonable way, or when their emotions have become more intense, and have them look for those kinds of thoughts. And then we teach them a system of how they can evaluate their thinking.
So it's like learn how to figure out and identify the emotion, the themes of your thinking pattern, and then picking up the skills or ability to change the way you think and change your behavior in general. And so CBT has a lot of skill set teaching people how to change the way they think and change the way they do things.
In fact, one of the things that we tell people in the first session is the way that you're going to get better is by making small changes in your thinking and your behavior every day. That's how people get better. And another thing we tell them is, I say, my goal is to make you your own therapist. So not only are we going to use some techniques in here, but I'm going to teach you how to do them, and you can practice them at home. And in that way, you can be your own therapist. And that's probably why people who have CBT as opposed to some other psychotherapeutic modalities or medication or some other treatment for depression, people who have CBT generally not only get better, but they stay better. The relapse rate is less because they learn these skills that they can use for their whole lifetime.
So you would say that one of the sort of the strength of CBT compared to other style of therapy is CBT train you to be your own therapist and advocating for self-efficacy. And,
That's exactly right.
uh-huh.
One of the things we do is to teach people, especially if they're depressed, to give themselves credit. So as much as possible, we give them credit, but we also teach them how to give themselves credit.
Uh-huh.
Now, what I've described to you so far has been the predominant force in CBT since the 1960s.
Okay.
But about 15 years ago or so, my father and Paul Grant and colleagues who were then at the University of Pennsylvania, but are now at the Beck Institute and elsewhere, developed recovery-oriented cognitive therapy for individuals with serious mental health problems, conditions like schizophrenia and bipolar disorder. And they started working with people, say, who were given a diagnosis of schizophrenia, who were living out in the community and were relatively higher functioning than the other group of people that they worked with, who were individuals who may have been in the psychiatric hospital for 10 or 20 or 30 or even 40 years. And they recognized that standard CBT, where we help people identify and respond to their negative thinking, just wasn't going to work with this population. They had a great deal of trouble identifying their thoughts. They had a great deal of trouble doing reality testing.
Sure.
Many of them had difficulty just learning some of the basic techniques of CBT, especially at first. And so what they did was to turn the treatment on its head almost. And instead of focusing on people's psychopathology, their symptoms, their negative thoughts and beliefs, they focused on ensuring that these individuals had positive experiences and that helped them draw positive conclusions about these experiences in order to bolster, to increase the intensity of their positive beliefs. So it's working within the cognitive model. In a certain situation, you have certain thoughts that lead to a reaction. But in this case, they try to provide that experience, a positive situation. And then they say to clients, well, so the fact that you were able to teach the staff member how to shoot baskets in basketball better, what does that say about you? And help the clients draw more positive conclusions. So nowadays, kind of the cutting edge in CBT treatment now is to use some recovery-oriented principles and integrate them into CBT. This is something that I wrote about throughout the third edition of Cognitive Behavior Therapy Basics and Beyond, which is really designed to treat individuals who have been diagnosed with more acute disorders, not serious mental health conditions, and uses some of these principles of recovery orientation throughout the book. Yes, there's still some emphasis on psychopathology, but a much greater emphasis nowadays on identifying people's strengths, their positive qualities, their talents, and so forth.
Well, I mean, when I was reading your textbook, I was still using the first edition, so I have to go get the third edition for sure. But I like what you said, because that kind of go back to where you were starting. You said you took classes with Martin Seligman. I wonder that has any influence on this movement, because
I think it definitely did. So Marty Seligman actually lives around the corner from me, and just by chance.
Oh, wow.
Used to live in the same community as my dad, and then my parents moved downtown about 12 years ago. But my dad and Marty, until my dad wasn't able to travel anymore, used to have lunch once a month.
Oh, wow.
And as you know, Martin Seligman is so well known for the strides he made in developing positive psychology. So I'm sure that those conversations with my dad must have been influential.
Yeah, because so for our audience, they know that CBT is not only known to deal with psychopathology, but is also could be applied to for people who don't have psychopathology but just want to live better in some way.
That's correct. Yeah.
So I guess I'm just wondering, are there any population CBTs harder to apply to in general, or you feel it's open to everyone?
CBT needs to be adapted quite a lot for people in different cultures, people at different developmental levels, people who have varying degrees of spirituality, It has to be adapted sometimes according to gender, age, interests, all kinds of characteristics. Sometimes it's a little bit more difficult to do standard CBT with people who have personality disorders.
Right.
And that's true with any psychotherapeutic modality that you might use. I happen to really prefer to work with people with personality disorders because it's so interesting to me, and sometimes a challenge to figure out how to adapt it so that these individuals who have had lifelong problems with relationships and sometimes with work, how to adapt it so that it sits right with them and so that it's effective with them. Sometimes you really have to work hard on the therapeutic relationship with people with personality disorders, although having a strong alliance is important for every single patient.
Sure.
Sometimes there's a myth that CBT doesn't really care about the therapeutic relationship. And I say, go back to my father's 1967 book, where he talked about the importance of a collaborative relationship and agreeing on goals and the work to be done in therapy sessions, and go read the entire chapter that he wrote in the first real treatment manual for CBT, which was Cognitive Therapy of Depression in 1990. And so the therapeutic relationship has always been an essential part of the kind of CBT that my dad developed. It's essential, it's just not sufficient. So usually having a nice relationship can help the patient, usually helps the patient feel better during the session itself, but doesn't necessarily prepare the patient to have a better week. And that's really the thrust of CBT sessions is what goals do you have for this week, or what problems are you experiencing that you want help with? And then orienting the session toward discussing these goals, coming up with an action plan. We used to call it homework, but people didn't like that term a lot. So now we call it the action plan between sessions. What does the patient want to do between sessions that are in alignment with his values and his aspirations? And that's another important part of the recovery movement, which we've adapted. And that is toward the beginning of treatment to ask patients, what are your aspirations? How do you want your life to look? What do you want to be like? And what are some of your key values? What's most important to you in life? Yes. And then having identified these values and aspirations, you can repeat them in session to help clients become more motivated to do sometimes hard work that they need to do between sessions.
So CBT is very, I would say, goal-oriented, because you set up a clear goal, a clear value, and you try to do the things that follow that and pursue that value. Right. And I would say that then if you're working with a CBT therapist, you will know you're working with one, because in the traditional therapy, there may not be some kind of structure and goals or agenda or action plan or homework.
Yeah. So maybe it would help if I talk about what a typical session looks like.
Sure. Yeah.
So let's say you're depressed. You meet criteria for a major depressive disorder. And there are 4 things that I will do toward the beginning of every session. And I can do them in any order, it doesn't matter. But I do these 4 things so that I get a good idea of what we should probably work on for the rest of the session.
Sure.
So one thing is, I just want to check in with a patient and see whether his symptoms are the same, worse, or better. Because of the recovery movement, I now also add a question: what was your sense of well-being like this week? If a 0 is no sense of well-being, and the 10 is the best sense of well-being you've ever had. So kind of check on kind of the more positive mood. Another thing that I will ask is, what do you want to talk about today? What goal do you want to focus on, or goals, or what problems do you want my help with? And problems are really the flip side of goals. So the problem is, I've been feeling lonely, and the goal is to feel more connected with people. The problem is, my house is a mess. The goal is start cleaning up one room or something like that. So we used to only ask about problems, but in a recovery orientation, we tend now to ask more about what the goals are. So then we discuss the problem or the goal, and we collect some information about what kinds of obstacles could get in the way of taking some steps toward this goal in the coming week. And the obstacles are usually either negative thoughts that we call them automatic thoughts because they just seem to pop up into people's minds. Or it might be some practical problems, so we have to just do some problem solving. Or it might be that the patient has some kind of skill deficit. For example, doesn't know how to make small talk with other people. So we use the standard CBT techniques in the service of helping the patient take steps every week toward the life that they want. And teaching them these techniques whenever obstacles come up so that they're able to take the steps. Anyway, so that's, but let me get back to the beginning of the session.
Sure.
We do a mood check, we set the agenda. I ask patients, what happened between last session and this session that I should know about? And if you're depressed, you're probably telling me negative things. And I am now very tuned into asking, tell me about any time this week when you felt even a little bit better, or anything that you accomplished this week, or anything that you found meaningful this week. And then I help the patient draw positive conclusions about these experiences, especially what does this positive experience say about you as a person, or maybe about other people, or about your life. So that's what we call the update. And then finally, we review the action plan that they had agreed to the week before. Then we talk about the goal. We figure out what steps the patient wants to take. We look for the obstacles that could get in the way. And then we try to resolve those obstacles. Probably the most important question we say is, how likely are you to take a walk 3 times this week? How likely are you to call your friend Janice and try to make a plan with her? And if clients say less than 90% likely, then we know we have to do a little bit more. Maybe there's another obstacle that we haven't identified yet. Or maybe there are some other thoughts that would get in the way. So I might say, well, what's that 10% that thinks maybe you won't do this? So we try to get out the obstacles. And then at the end of sessions, we ask for feedback. And we actually ask for feedback throughout the session to make sure that the patients are understanding us and have agreed with what we've said or what they've said. And we also will stop the session if we, not all the time, but a lot of the time, if we notice that the patient seems to be having a negative reaction in the session. So we notice a change of affect on the face, or the body language suddenly looks defensive. We might very well stop and say, oh, you're looking a little upset. What was just going through your mind? And then we need to find out if there's some problem we need to solve. But at the end of sessions, we also ask for feedback. Maybe for the first 3 sessions or so, we might say, what did you think about the session? Was there anything you thought I got wrong, or you thought I didn't understand? Is there anything different that you want to do next week? And after a few sessions, you can just say, what did you think about the session? And here's something that's really crucial. Whenever patients give us negative feedback, the first thing we have to do is to give them positive reinforcement. It's so good you told me that. And it is good. Some therapists don't like to hear negative feedback, but if there's a problem, how could you solve it if you don't even know what it is?
Of course.
So we really need to make therapy feel very safe for patients so that they're willing to give us honest feedback so that we can adapt it and tailor it so it's right for them. Anyway, that's pretty much how the sessions go. They sound a lot more like a conversation. The way I just described it sounds a little bit like step 1, step 2, step 3, but really it with an experienced CBT therapist, it sounds more like a conversation.
Behind the scene, there are plans, there are strategy, there's structure. And I think a good clinician, a good educator do have something similar in some way, right? Because when we teach and when we work with students, you kind of also have some kind of goals and plan and action items to work on. And
that's right. And you have kind of in mind a blueprint or a map of which concepts are going to be important to teach your your students first, and then building on that, what might be the second concept. And it's similar, I think, with psychotherapy too.
And the ultimate goal is to train them to be their own therapists, right? That is the ultimate goal, where they can go on their own. And so can you say a little bit about techniques? Because I ran into the typical example, especially if you run into narcissistic clients, right? They're like, oh yeah, I know, I need to change the way I think. I knew that.
And how would I respond to that?
Yeah, how do you respond to it?
I would say that's terrific that you already know how to do this. So we just have to figure out whether you're doing it effectively enough or often enough. I assume there's something going on that made you want to come in and talk to me about it. So maybe you just need a little bit of a tune-up, and then you'll be on your way.
Wow, you're very encouraging. So how many sessions do we expect to work with a CBT therapist? That's a typical session you describe.
Yes.
How long, what's the typical number of sessions people need to see a therapist?
Well, ideally, there's no set number, because it's varies enormously from person to person. We've had people who've come in who pretty much just have some kind of problem in life, and maybe very mild symptoms, and maybe 2 or 3 sessions is enough. Then we have people who have really struggled, kind of across the board in so many different ways ever since they were children. They often will need many more sessions. Someone with an acute disorder like depression or anxiety who's really motivated to work might need 6 to 10 sessions. Someone with who's been diagnosed with a serious mental health condition like schizophrenia may need a great number of sessions over years. But what we found with people, even if they have a serious mental health condition, is that they can have a certain number of sessions to begin with, and then go out and live their lives, and then come back when they run into a problem and have probably a shorter course of treatment, and then go out again and then come back when they need to. And really, I think that's a good model for almost anybody. Is you learn the skills, you learn how to be your own therapist, then you go out, you do it, you run into trouble, you try to handle the problems yourself. If you're successful, then you don't see your therapist again. But if you're not successful, then you come back to treatment. Now, one of the things that I just wanted to say, sometimes the therapist workplace will say you can only have 10 sessions with a patient, or the insurance company will say we will only pay for 10 sessions with a client. Well, that's not a very good way of handling people's difficulties, especially if they have psychiatric disorders.
Sure.
And, if possible, we would like the decision about how many sessions to be made collaboratively with the patient. And so when I see that a patient is starting to feel better and is really doing the action plan between sessions, then I might suggest that we look at advantages and disadvantages of spacing our sessions to every other week instead of every week. And if the client is agreeable, then we'll try doing that, with the understanding that if I've guessed wrong and the client needs to come back every week for a little while longer, that's fine too. We will do that. But we base treatment on the conceptualization that we make specifically of an individual client, and adapt treatment, as I said, as needed for that client. We don't use treatment manuals. I really am very much against treatment manuals. I think treatment manuals are absolutely essential so that so that clinicians can learn what are the evidence-based techniques and interventions to use with clients. And then they need to put this knowledge inside the framework of how do I conceptualize this client? And also, what does the client want? Because I need to be highly collaborative with the client.
Sure.
So we always use the principles from treatment manuals, but we don't use treatment manuals themselves.
Right, that makes sense. you don't want to follow a manual to see a real person. That makes a lot of sense.
Yeah.
Which I guess the reason why people have the concept of we need to follow treatment manual probably came from the research. Is that where the impression people came from?
Frankly, you need research if you're doing outcome trials, because you need to make sure that the treatment is given in a pretty standard way. Otherwise, we don't really know, was it just the personality of the therapist or some idiosyncratic things that the therapist did that led to either a better or worse outcome? Or is it really a fair test of the treatment? So you need them for the studies, but I think that they are not indicated when you're out there in practice.
Right.
Now, it may be that you have a textbook kind of client and the treatment manual absolutely works for that client. But I think for the most part, you're going to find that clients don't fit some prototypical client,
sure.
and that you do need to make some changes.
So I think CBT is known to have a lot of scientific evidence and scientific research.
That's right.
And it's been for several decades already. What is the trend in the research right now for CBT? Back then, it's more focusing on depression, anxiety. Where is the direction going right now?
First research study, I think, was published in either 1977 or 1979. So there have been decades. There probably have been over 2,000 outcome studies that have shown that CBT is effective. So there's a lot of research. There is research on the effectiveness of CBT for a whole range of psychiatric disorders, for medical problems with psychological components, and for some psychological problems like procrastination or relationship problems, things like that. There's a lot of research recently on how effective is CBT for various populations. So maybe nurses who work in India, or I just made that one up, or people of the Hispanic culture who live in a large city in California, something like that. So there are many kinds of studies like that. There's also studies about using artificial intelligence and online programs and apps and things like that for people. There's a lot of research that's being done that integrates CBT with other psychotherapeutic modalities. Some people define CBT as a psychotherapy that uses cognitive and behavioral techniques. And I don't think that's the definition at all. That is way too narrow. The very narrow definition. It's a psychotherapy that's based on the cognitive model. And then we use techniques from any evidence-based treatment, as long as it fits into our cognitive conceptualization, and we make a collaborative agreement with the patient to do it after we provide them with a rationale. So there are some forms of CBT which are kind of narrow, and they say, do this, don't do that. There's extremely little in CBT that we would say, no, you wouldn't do that. I mean, certainly we would very infrequently use something like paradoxical intention, because our one of the principles is to be quite transparent about what we're doing. But really, we can take techniques from acceptance and commitment therapy, dialectical behavior therapy, from positive psychology, when working with personality disorders, sometimes from psychodynamic psychotherapy, from compassion-based psychotherapy. I don't want to spend time enumerating all of them. But I think CBT is really the integrative therapy in that it's based on the cognitive model, but we use techniques from just about any evidence-based modality.
I think in any school of therapy, you all need to deal with cognition and need to learn to identify the way you think, and you definitely need some way to learn how to manage that story.
And in CBT, I think we do it in a kind of an organized way.
Yeah. I guess just curious about your personal interest. Where do you wish the field to go 20 years from now? Let's say, like, how do you want to see cognitive therapy evolve in the future?
Well, one important aspect, I think every CBT therapist should use some recovery-oriented techniques in their work. So putting much more of an emphasis on the positive in addition to psychopathology. So that's one stream. Another stream is the use of artificial intelligence, I'm hoping, it may never, but I'm hoping it can get to the point where millions and millions of people can get CBT. And it will be so cost effective because they can do it through some kind of computer program. Right now, the computer programs that are most successful are the ones in which the patients also have a therapist.
Okay.
So it's therapist guided computer programs. So that's another one. Another one is really the adaptation to different cultures, especially different economic systems. So in one African country, there are friendship benches, and they teach some of the elder women in the community how to do some basic problem-solving techniques and behavioral activation techniques. And they sit on a bench outside, and the women who are depressed come and sit with them.
Oh, wow.
And they really are giving, this form of CBT to them. In India or Pakistan, maybe Pakistan, they're training health workers who work in primary care to do CBT for people who are depressed and anxious. And I think that there are so many cultural adaptations like that can be made. We don't need people necessarily to come to a therapist's office anymore.
Sure.
Let's figure out different ways of delivering the treatment in ways that are cost effective and acceptable to the populations, wherever they are in the world.
Your point reminded me that recently our mayor, Eric Adams, just required all public school to teach mindfulness to the kids. Yes. How you feel about combining that, let's say, with CBT techniques, CBT apps? Is that something you're thinking of?
Oh, yeah. No, I think it's terrific. And it's especially important when people have a dysfunctional thought process going on, like anxious obsession or depressive rumination or continual self-criticism. In those cases, kind of standard CBT techniques just don't work very well. We do mindfulness in a slightly different way, I think, from most cognitive behavior therapists. But at the Beck Institute, what we do is first, we find out what the patient sees as the advantages and disadvantages of engaging in this unhelpful thought process, like let's just say worry for people who have generalized anxiety disorder. They almost all of them see some positive points about the experience of worry. So they'll think, well, if I worry about something in advance, then maybe I can figure out what kind of problem could come up and I could avert that problem. Or if I worry about something, then that shows that I'm being a responsible person. So they often have some, what they consider to be positive advantages to experiencing that. And so the first thing that we have to do is to help them recognize, are those really advantages? And by the way, what are the disadvantages? So that they'll be willing to try to give up this habit they have of worry. Then we set up the mindfulness as a behavioral experiment. We get them to start to worry right in the session itself, maybe for about 3 or 4 minutes, really try to get it going, because we want to duplicate the experience that they're going to have at home. So we get them to really worry quite a lot in the session for about 3 or 4 minutes. And then we lead them through a 5-minute mindfulness exercise, and we record it on their phone so that they can listen to it at home. We frequently will just give them the choice. Do they want to do a body scan? Do they want to focus on their breathing? Do they want to focus on an external object? If they have great self-criticism, then we often suggest that they do a more of a compassion-oriented mindfulness exercise. But let's say they were going to concentrate on their breathing. Then we lead them through this exercise. We get them to focus on their breathing. Every time they find that their mind wanders, we ask them to gently bring their attention back to their breathing without criticizing themselves. We let them know that minds are built to wander. And so, of course, their mind will wander. No need to be critical about it. But what we really want them to do is just to notice when their mind wanders and gently bring it back. And then at the end, we ask them how they feel now compared to when they were worrying before we did the mindfulness exercise, and usually they find that the worry is much less and that they're feeling better. And then we just have them listen to this 5-minute exercise every morning. And then we ask them to do some informal mindfulness during the day. But if they find that they are engaging in a worry process, then to, again, if it's convenient, hopefully, is to play the recording during the day and to see whether they can disrupt what's going on. Many of them have done mindfulness before they've come to treatment, and it hasn't worked for them. And probably it's because they kind of learned it as a standalone technique.
That's right.
And so that's one reason why we have them really engage in that dysfunctional thought process right in the session. So it demonstrates to them that it works, even if their mind is really consumed with that negative thought process. And then we just encourage informal mindfulness when they're brushing their teeth or washing the dishes or taking a walk or reading a book to their children, whenever they want to. And we find that that's enough. They don't need to do 20 minutes a day, 30 minutes a day, an hour a day.
Sure.
This brief exposure, and then doing it periodically throughout the day is enough.
So CBT, I think one of another strengths is really it can integrate with different style of techniques very easily. You could really work together and make very hands-on for people.
But we're always working from a cognitive conceptualization. So we understand what the worries are, but we also understand the research that shows that when you try to use Socratic questioning or cognitive restructuring as a major technique about the thoughts people have when they're worrying, that it just doesn't work very well. And what we have to do instead is to teach them how to detach from the worry thoughts and how to shift their attention to something else. And one of the things I frequently find myself saying to patients is, well, what would you like to be thinking about? And mindfulness can help you do this because it can really reduce the dysfunctional thought process and allow you to think about what you want to be thinking about.
My personal feeling is like CBT is always evolving, and just like more and more technique can become working together and become something that's very useful for myself and others. Any final words or thoughts for our future clinicians?
Well, if it's okay, I'm going to say two things.
Sure.
One is, I thought you might ask me about what are the challenges to the field of cognitive behavior therapy.
Okay.
And one of them is how many people say that they are cognitive behavior therapists when they've never been certified by the Beck Institute or any other organization, and they don't do anything that resembles cognitive therapy when they describe what they do. Even worse are people who really believe that they're doing CBT when they're really not. And so I think it's important, if anyone is seeking CBT, is to make sure that they really are getting CBT and not some watered down version of it. Anyway, I'm so glad that some of your students are going to pursue this field. To me, it's one of the most interesting things that you can do. I have to really honestly say, I learn from every single patient that I treat. And as you mentioned, the field is so expanding in so many different directions. I didn't even get a chance really to talk about some of the exciting progress that's been made in terms of cognitive science and how that influences CBT. But if you're interested in neuroscience, if you're interested in physical health problems, if you're interested in people's psychology, if you're interested in teaching, there are just so many applications of CBT. So I'm so glad that your students might go into this field. Tell them to sign up for our newsletter so they can really just find out what's going on in the field.
So for anyone who's interested to learn more, they could visit Beck Institute's website. I'm sure you have a lot of information there for them to continue. Thank you so much, Dr. Beck. I personally feel very happy to have a conversation with you. I learned about cognitive therapy, and I feel there's still a lot for me to learn, and I'm just very happy to catch up on what's going on in the field. And I thank you so much for coming to us.
Well, I'm just honored that you invited me, so thank you very much.
Thank you. And I hope you enjoy our conversation with Dr. Beck, and check out Dr. Beck's Beck Institute's website. There's a lot of information where you can pick up more about cognitive therapy And so we can all be our own therapist one day. So every month, third Friday, 7 p.m., stay tuned.